We already saw that echo helps us to make the diagnosis, and it also allows us to quantify the severity of mitral stenosis. Now I'll show you that it is also very important to decide how we can treat the patients. Valvuloplasty is a method where we use a balloon, a special balloon, a so-called Inouye balloon, to expand the mitral valve. This balloon is placed via a transvenous approach into the right atrium, transeptally to the left atrium, and then into the mitral valve area. And by expanding, we kind of crush the commissures and thereby open up the mitral valve. What are the indications for mitral valve valvuloplasty? Well, you have to have moderate to severe mitral stenosis, so the mitral valve area has to be below 1.5 square centimeters, or if you have very large patients, 1.8. The valves have to be suitable for the procedure. They have to be applicable and non-calcified. We'll talk about that in more detail later. And the patients have to have symptoms, so it has to be a symptomatic form of mitral stenosis. There are several contraindications or situations where you should not perform valvuloplasty, but where you should rather proceed with surgery. If you have significant MR, why? Because MR will usually increase after the procedure, and thereby it's probably better if you operate these patients in the first place. You should not perform valvuloplasty if you have a thrombus, because you can dislodge the thrombus and thereby cause embolism. If you have additional valvular disease, for example, tricuspid stenosis or tricuspid regurgitation or aortic valve disease, then you should also probably prefer surgery and not valvuloplasty. And the same is true if you have coronary artery disease. The results for valvuloplasty are actually quite good. Usually you can obtain mitral valve areas somewhere above 1.5 square centimeters with no significant regurgitation. We do not only see an increase in the mitral valve area, but also a decrease in the mean gradients. The patients also improve with respect to the pulmonary artery pressure. We can find an increase in the cardiac output, a reduction in LA stiffness, and patients who are in sinus rhythm have more atrial kick, in other words, a better filling of the left ventricle. So even though we do not have a complete normalization of the size of the mitral valve orifice, we do see significant hemodynamic and symptomatic improvements. But what is the role of echocardiography? It's not only in making the diagnosis and determining the severity of mitral stenosis, it's also in assessing the morphology of the mitral valve. Why is it important? Well, we saw previously, because not all patients are suitable for this procedure. And we have to look at certain factors. For example, the mobility, subvalvular apparatus, the thickening, the degree of thickening of the mitral valve, the presence of calcification, and in particular at the commissures if calcification is also present there. In 1988, Wilkins, Bloch, Wayman, and others published a paper where they showed that if we use the different characteristics of the mitral valve and we score them, then we can determine if patients have a good outcome after mitral valve valvuloplasty. So using this score, we can determine the suitability for this procedure. Basically, the Wilkins score grades all those individual features that I just mentioned. So the degree of thickening, the mobility of the leaflet, the degree of calcification, and subvalvular apparatal involvement. You will find a more detailed description of the score in your fact sheet. I now want to show you some examples of the different morphologic criteria which are in the Wilkins score. First, let's take a look at the subvalvular apparatus. To mention up front, the subvalvular apparatus is best visualized in a 3-chamber view or also in a peristernal long axis view. What we have here is a severely affected subvalvular apparatus with chordal shortening, chordal thickening, and also fusion. I would probably give a 3 to the subvalvular apparatus. The mobility of the mitral valve is best seen in a peristernal long axis view. Basically, what we look at is the degree of doming of the anterior mitral valve leaflet. Here's an example where you have good mobility of the basal, the mid portions of the mitral valve. Only the tips of the leaflet are impaired in their motion. There's a lot of doming, so I would grade this as 1. To determine the thickness of the mitral valve, you should be using all different views, all views that are available to you where you see the mitral valve, because you have to look at all different portions of the mitral valve. This is an example where the posterior leaflet is very significantly thickened. The anterior leaflet maybe not as much, but it's not only the tips of the leaflet, but also the basal segments which are affected. I would grade the severity of thickening as 3. Finally, let's take a look at the degree of calcification. Again, you should be using at multiple views and looking at all different aspects of the mitral valve, in particular also the short axis view, because there you can see the commissural region and determine if calcification is also present there. Calcification in the commissural region seems to be a very important and negative predictive factor for the successful outcome of valvulopathy. But here is the peristernal long axis view in a patient, and what you nicely see here is a small area of calcification here and here. So not very much calcification, but still more than none. So I would grade this as 2. And what do you then do with all these numbers? Well, you just add them up, and if they're below 8 or 9, then you would proceed with valvulopathy. So then he's good for the procedure. If he's somewhere in a range between 9 and I would say 11 or 12, then he's maybe not optimal, but you can still perform the procedure if the patient, for example, does not have any other option. If he's above 12 or 13, you should just leave it. Aside from the Wilkins block score, there are also other things you have to take into account. First of all, the presence of mitral regurgitation and its degree, the presence of calcification in the commissural region, tricuspid regurgitation, and left atrial thrombi. Just to mention again, the pressure half-time method is not reliable immediately after valvulopathy. Why is that so? Because after the procedure, we have a dramatic change in the chamber compliance and also in the transmitral gradients. And these two factors strongly influence pressure half-time. So you can use it, but it does not necessarily really reflect the true mitral valve area. What complications can you find after valvulopathy? A failure rate of 15%, a mortality of 0.5 to 4%, embolism of 0.5 to 5%, and severe regurgitation in 2 to 10%. Here's a Doppler tracing before and after valvulopathy, which shows you how good this method actually is. You can immediately see that the mean gradient has dramatically dropped after the procedure. You see that the area under the spectrum is much larger here than here. However, note that the maximum velocity did not really change as much. Another indication that the maximal gradients are not as good in assessing the severity of mitral stenosis. In addition, you can see that the slope of the curve has also changed, so the pressure half-time has significantly decreased. Even if the mitral valve area, which we calculate with the pressure half-time, is not exact, we can see that there actually is an increase in the mitral valve area. Obviously, when you assess these patients after the procedure, you should also be using color Doppler. Why? To look at the degree of mitral regurgitation. This is before the procedure, no regurgitation, and this is after the procedure. You see a jet right here, probably moderate mitral regurgitation. But the interesting thing is that we have the impression as if the regurgitant jet goes right through the anterior leaflet, as if the leaflet were perforated. This is usually an indication that the regurgitation comes from the commissural region. To better appreciate that, we can use a short axis view, and in reality we were correct. The regurgitant lesion is right here at the commissural region. But this is basically an effect that we want to achieve because we want to rupture the commissure. So right in the region of this commissural rupture, we have the origin of the mitral regurgitant jet. Another issue which is important is pulmonary pressure. We know that pulmonary pressure drops immediately after the procedure. However, rarely does it reach normal values. In the following months, there is a continuous further drop of pulmonary pressure, and in most patients, or at least in some patients, the pulmonary artery pressure even reaches normal values. if you follow these patients also for pulmonary artery pressure, you can find those patients who are weak responders or non-responders. Most patients with mitral stenosis also have tricuspid regurgitation. In this study, published 2008, 50% of patients had moderate or severe TR. And the degree of TR usually drops after the procedure. In this study, only 12% had moderate TR and no patient had severe TR. The decline in the TR is usually related to the drop in pulmonary pressure. Still, you have to be aware that some patients still have significant TR and that further treatment of TR is required. And finally, if you follow patients after valvulopathy, also place the colored Doppler sample volume within the region of the interatrial septum to detect so-called iatrogenic atrial septal defects. These defects are a result of transseptal puncture, and even if they're fairly small, there can be significant shunt, left to right shunt, because we have elevated left atrial pressure in the setting of mitral stenosis. Basically, it's a iatrogenic form of the so-called Lutenbacher syndrome, which is the combination of a congenital mitral stenosis and an atrial septal defect.
So you saw how important echo is. Practically, how do we go about? Well, if we have a patient who has mitral stenosis and he is symptomatic, we assess him for the potential to perform valvulopathy. We use a transthoracic echocardiogram. We look at the different features that we have of the valve. And if we think that the patient is a good candidate, then we perform transesophageal echocardiography before the procedure. Why? Because we want to exclude that he has a thrombus and we want to look at the morphology once more, and also at the interatrial septum. And then we perform the procedure. Usually we do not need a transesophageal echo during the procedure, only in some patients where we believe that it might be more difficult. In most patients, we look at the echo right on the table. We look at the gradients again. We perform pressure half-time measurements. We look at the severity of MR. And then we perform valvulopathy. And after every opening of the balloon, we check on the result. We see if the regurgitation is more. We try to check if the mitral valve orifice area has expanded. And then, if we think everything is okay, we send him up to the ward, and next day we bring him down again and look at the gradients again. This is how we would use echo in our setting.